Welcome to our Affordable Care Act 101 course, What Employers Need to Know. My name is Susan Grassli and I'm an attorney here at GBS Benefits. Today we'll be talking about the Affordable Care Act provisions that affect employer group health plans. That will include giving you a high-level background information on the ACA. Then we'll talk about the exchange marketplace, the employer mandate, also known as the employer shared responsibility, the individual mandate, also known as the individual shared responsibility, GBS tools that we've created to help you with compliance in these particular areas, and the market reforms. A brief background can be helpful when you're trying to understand a particular rule or statute. The ACA was actually two separate acts. Combined, they're referred to as the Patient Protection and Affordable Care Act, or the PPACA, Healthcare Reform, Obamacare, Affordable Care Act, or ACA. I think most commonly these days you'll hear it referred to as ACA or Healthcare Reform, and I'll be probably using both of those terms today. The effective date is different for each provision. There's actually several different provisions within this act, and so but most were effective between 2012 and 2014. Some were not effective until 2015, and actually some were indefinitely delayed, so some of them haven't actually gotten into effect yet. Generally, when a federal law is passed, there will be a U.S. department that will be assigned regulatory authority. In this case with the ACA, there are 3 U.S. departments that were assigned regulatory authority. Sometimes they're referred to as the departments. Sometimes they're referred to as the tri-agency, but those 3 agencies are U.S. Department of Health and Human Services, or HHS, U.S. Department of Labor, or DOL, and the U.S. Treasury, sometimes referred to as just the Treasury or IRS. Regulatory authority provides power to do a few things. First of all, it allows these agencies to provide more detail and clarity for those who are supposed to comply with these rules. You know, oftentimes when a law is passed, that you just cannot get the kind of detail you need in order to understand how to specifically comply. So this takes many forms, including proposed rules, interim final rules, frequently asked questions, safe harbors, letters, templates, and so on. But the bottom line is, when we have questions about how to comply, usually we're looking at the regulations, not the law itself. The departments also have other authority that falls under regulations, a regulatory authority, and that means they have the authority to investigate compliance, and they also have authority to assess penalties and to tax. So just one slide quickly on ACA and politics, just because I get questions about this sometimes. The ACA was passed during the Obama administration, and that is often why it's referred to as Obamacare. The Trump administration did not like the ACA and tried to repeal and replace it, but did not succeed. However, the administration did successfully chip away at the ACA using various other strategies. Biden administration wants to repair and rebuild the ACA, and Congress generally, as you might be aware, is divided on some of the provisions with the ACA, but they are actually in agreement on several of the provisions. A couple of examples of those provisions are the provisions that require coverage of dependents up to age 26 and not allowing group health plans to exclude some based on or delay some based on pre-existing conditions. Now, the U.S. Supreme Court has weighed in on the ACA 3 times since this was passed, and the bottom line, however, on all of this history is that the ACA remains intact and in force, at least for the foreseeable future. I like to divide the ACA into four main categories. First, the exchange marketplace and the subsidies that are available there for certain individuals and families. The employer mandate, or also referred to as the employer shared responsibility. The individual mandate, or individual shared responsibility. And then we have a kind of catch-all category of market reforms. The exchange, employer mandate, and individual mandate can kind of be considered the heart of healthcare reform because they dovetail together to create the structure of and the intent of the act. And then we have, within the market reforms, we have several other provisions that are meant to be improvements in the healthcare market. So let's move on to discuss in a little bit more detail the exchange marketplace. The rule here is that states must provide an online health insurance marketplace for individuals and families within that state. Now, this was originally referred to as the ACA exchange. It was later referred to as the marketplace, and that's why we have up here on the top exchange/marketplace, so that you're not confused if one word is used versus the other. The intent of this rule is to provide consumers, individuals and their families, a one-place, one-stop, easy side-by-side comparison of a variety of different health insurance plans. And when they do this, they can enroll on their own online, or they can get help from agents or brokers, or from what's called assisters. Now, the states have a couple of options here that they were given when this rule came out and was effective. They needed to choose how they wanted to run this exchange. They could run the exchange on their own, or they could run the exchange through the help of the federal government. Specifically, one option is called the state-based marketplace, and that's again where the state runs it their online platform independently. And this is where individuals enroll through the marketplace created by the state. Then there's kind of a hybrid option, which is a state-based marketplace with a federal platform. And that basically means that the state is using the actual functions of the federal website, but and so that means that they're using it for enrollment, and they go through healthcare.gov. But they do take on some role of ensuring that it runs. And then we have the third option, which is called a federally facilitated marketplace, where the state basically says, hey, we don't want to have to worry about this requirement. We're giving you permission to run our state exchange for us. It's called, some refer to it as a federally facilitated state exchange. I added a map here so you can visualize where each state is, at least currently in 2022, and also so that you can understand what your employees might be dealing with if they decide to go to the exchange and purchase coverage there. You can see about half of the states here have asked the federal government to facilitate their exchange for them. And then we have about a dozen states that are running the marketplace exchange on their own. And then we have just maybe a handful of states that are the hybrid option. Now, within the exchange, there are certain rules about the kind of plans that can be offered there. All plans that are offered by carriers in each of the state exchanges must meet certain standards that include a metal level. And what that means is, you can see here that there's a bronze, silver, gold, and platinum. And each plan, if you look at the bronze version, must meet at least the 40% level, and that 40% means that the participant is required to pay no more than 40% of the total out-of-pocket costs under the plan. For example, co-pays and so on. That this does not include monthly premiums. This is all the other out-of-pocket costs, and so that the plan pays at least 60%. And then if an individual wants to buy a little bit richer plan, they can pay a little bit more, and so that they're paying only 30% of the out-of-pocket costs. If they want to pay a little bit even more, they can buy into the gold plan, which means that they would pay only 20% of the out-of-pocket costs. And then of course the platinum would be the richest, most expensive plan, but the participant would pay only 10% of the out-of-pocket costs. Now, another important thing to understand about the exchange is the ACA subsidies that are available for certain individuals and families when they purchase coverage in the exchange. These individuals and families are those with a lower household income. And there are two different kinds of subsidies. There's one called the premium tax credit, or PTC, and that subsidy helps them pay for the cost of the monthly premium. And then there's another subsidy that's called cost sharing subsidy, and that helps individuals or families pay for all the other costs, meaning the out-of-pocket costs. Now, household incomes that qualify for the ACA subsidies have to have household income within a certain percentage of the federal poverty level. Now, household, you can see that on this first bullet here that that households with income below 100% of the federal poverty level are not going to qualify for a subsidy in the exchange or even purchasing in the exchange. They're in fact going to qualify for federally funded Medicaid. However, households with income between 100% and 250% of the federal poverty level will qualify for the cost sharing reductions, and households with income between 100% and 400% of the federal poverty level will qualify for the premium tax credit, or the PTC. Now, that PTC is important to remember because that is a subsidy that affects large employers. The reason for this, is that the subsidies can trigger the penalties if an employee, and this is the situation in which a large employer would have a penalty assessed against it. Number one, if an employee gets a subsidy in the exchange, qualifies for it, meaning that they got the premium tax credit, their household income is somewhere between 100 and 400% of the federal poverty level. The employee is full-time, and the employee was not offered by you as an employer an affordable minimum value health coverage plan. Now, I want to pause for a minute to give you an update on the premium tax credit, because there's a little bit of a change currently with the premium tax credit. Some of you may recall that the American Rescue Plan Act, ARPA, that was passed in March of 2021, if you recall, it provided various kind of relief due to COVID. It expanded the premium tax credit in a specific way temporarily for 2 years. Specifically, it temporarily removes the 400% cap. In other words, remember on the prior page we talked about how somebody would qualify for the premium tax credit if their household income is somewhere between 100 and 400% of the federal poverty level. So that maximum amount can now be exceeded, at least temporarily, so that some households who have household income above 400% of the federal poverty level could be eligible for the premium tax credit. Now that's important because the premium tax credit, again, is the credit that can trigger a penalty against large employers. So this is how it works. If the cost of the monthly premium for the benchmark plan in a particular state is greater than 8.5% of household income, this individual family will qualify for a premium tax credit even if their household income is above 400%. Now, the total expected income, household income, is calculated against the second lowest cost silver plan. Remember, we talked about bronze, silver, gold, and platinum, and that's the plan that they're looking at for the cost. Now, the effect of this temporary change is significant because, as we've just discussed, the premium tax credit triggers possible penalties, ACA employer mandate penalties against large employers. So the expanded premium tax credit window, meaning 100% to possibly above 400%, means that there's an increased likelihood of individuals qualifying for and using the premium tax credit, which means there's an increased likelihood of that penalty being triggered against large employers. So it's just a reminder. We always want to make sure we're in compliance with this rule, but there's an extra incentive to make sure that you're compliant with the employer mandate and offering coverage to the individuals that you should be offering coverage to if you want to avoid the penalties. There's one more thing that we need to discuss before we move from the exchange marketplace to another topic, and that is the notice to employers that an employee qualified for the PTC or the premium tax credit. HHS, if you recall, is one of the U.S. departments that's tasked with regulatory authority over the ACA, and they're the department that will send Letter 1411. Letter 1411 is a letter or notice that informs large employers that one of their employees qualified for and is using a premium tax credit. The first thing that is important to remember is this is not a penalty letter. Penalty letters under the ACA are sent by the IRS. The second thing you need to do is check your employee status. Now, here's kind of a list of different categories. The first category is if you check your employee and that employee is part-time every month and will remain to be part-time in that calendar year, you don't need to worry about a penalty being assessed against you based on a premium tax credit that this employee received. If the employee is full-time and has been offered affordable minimum value coverage, there will be no penalty either. The problem is if you have an employee who is full-time and was not offered affordable minimum value coverage, you're going to be exposed to a penalty because that premium tax credit is going to trigger that penalty. So it's important for you to determine your employee status, and if this employee is a full-time employee or will be a full-time employee and has not been offered an affordable minimum value coverage plan, then you might want to consider offering that employee the plan. So the last thing you need to do is decide whether you want to respond to the letter. Now, responding to the letter is not required. If it's valuable to respond, if you have an employee who is full-time and was offered coverage, that would be the most important time to respond. In other words, you received this letter, you heard they purchased coverage in the exchange, and when you researched this employee is full-time, was offered coverage, the offer was affordable and met minimum value, but they opted out and then went to the exchange. You might want to let the HHS know that, so I would respond. The other two categories, it would depend on the situation whether you would find it valuable to respond. We've finished talking about the exchange marketplace, and now we're going to move on to our discussion about the employer mandate. The employer mandate is sometimes referred to as the employer shared responsibility. Sometimes people shorten it even more and refer to it with an acronym, ESR. Under this rule, an applicable large employer, ALE, that's the official terminology that the rules use, ALE. So sometimes you hear large employer, sometimes you hear applicable large employer, sometimes you hear ALE. It's all the same thing. But a large employer avoids employer mandate penalties if that employer offers affordable minimum value health coverage to at least 95% of its full-time employees and their dependents. Now, to be clear, there's no requirement for a large employer to offer coverage. However, there's a penalty that an employer is possibly exposed to if certain events take place. And these are the specific events. We've talked about them already, but we're going to repeat it because it's important for you to remember this. A penalty is only triggered if a full-time employee purchases coverage in the exchange marketplace, meaning that employee is full-time, that employee qualified for, when they purchased in the exchange, a premium tax credit. Not everybody does qualify for that when they purchase in the exchange, and that employee was not offered by the large employer affordable minimum value coverage. Now, another thing that's important to remember is that even if a large employer is not compliant with this rule and they somehow don't offer affordable minimum value coverage to at least 95% of their full-time employees and their dependents, then there still may not be a penalty. They could completely fly under the radar. It is only triggered when these events take place, and specifically the premium tax credit in the exchange. I think it's helpful here to understand the reasoning behind this rule. The intent Congress had, or one of the intents, is to get more people with health coverage so that more people have those costs taken care of for them. And the thinking behind that is large employers have the capacity to offer these benefits to their employees, at least those who are full-time. So we'll have those people taken care of, and we'll take care of the rest, meaning those who aren't employed with a large employer, or those who aren't employed at all, or those who are part-time, or those who are struggling. So if an employee goes to the exchange and qualifies for a subsidy, and that employee works for a large employer, they'll still get the subsidy, but then the employer will need to help pay for that subsidy, thus the penalty. So let's talk a little bit about the penalty. Penalty is divided into two parts, penalty A and penalty B. Penalty A is the larger penalty, and that's the penalty that's imposed when a large employer fails to offer minimum essential coverage to at least 95% of full-time employees and their dependents. Now let's talk about what some of those words mean. Minimum essential coverage is just basically coverage offered by an employer. There's really not a definition beyond that. So 95% of full-time employees is on purpose. It's not 100%. The hope is that large employers will offer to 100%, but there's a 5% margin of error that employers can intentionally or unintentionally use up, just to give them a little bit of a buffer there. And they need to offer to their full-time employees, not part-time, and their dependents, and that means dependents but not necessarily spouses. Now, a lot of employers do offer to spouses as well, but under the rule they're not going to be penalized for failing to do so. It's just the dependents that need to be offered. Penalty B is a smaller penalty, doesn't cost as much, and that's imposed when a large employer actually does offer minimum essential coverage to at least 95% of their full-time employees and their dependents, but what is offered, that group health plan, does not meet affordability and minimum value standards. So let's dive in just a little bit more on the A penalty. Again, it's imposed when a large employer fails to offer a group health coverage to at least 95% of their full-time employees and their dependents. And again, remember, spouses don't need to be offered, but obviously in most cases groups do that. And at least one full-time employee purchases health coverage in the exchange and qualifies for the PTC subsidy, or the premium tax credit. And again, the B penalty is imposed when a large employer actually successfully offers a group health plan to at least 95% of their full-time employees and their dependents, but the plan is not rich enough, meaning it doesn't meet both affordability standards and minimum value standards. And of course, at least one full-time employee needs to go to the exchange, purchase coverage there, and qualify for a premium tax credit for a penalty to trigger. Now let's talk about definitions here. We did talk about that on the other page, so the other slide. So affordability and minimum value, what do those mean? Minimum value we discussed when we were talking about the exchange, actually, and I don't know if you recall, we had a diagram that had 4 metal level plans that are what the types of plans that are offered in the exchange: the bronze, silver, gold, and platinum. Minimum value is represented by the gold plan, meaning it's the cheapest plan, but that is where the employee is not required to pay out of pocket. And remember, out-of-pocket costs do not include the monthly premium. That will be addressed in affordability. The employee is not required to pay out-of-pocket costs that exceed more than 40% of the total actuarial value of the plan. An easy way of referencing that or wrapping your head around what actuarial value means is just if you say the total cost of the plan. And then affordability. Let's back up on minimum value. Minimum value is typically offered in most group health plans, unless you're trying to do a skinny plan, which we don't typically recommend. You're going to be offering a minimum value plan that is paying at least 40% of that the plan will pay at least 60% of the out-of-pocket costs, so that the participant doesn't need to pay more than 40%. The kicker, or the hot spot, really is the affordability part. Affordability under this rule means a plan where an employee is not required to pay more toward the monthly premium, so the monthly premium cost, based on single coverage, more than 95% of household income. So let's dive into affordability just a little bit more, because this is a bit of a hot spot. And again, a plan meets affordability when the monthly premium cost for single coverage for the lowest cost plan, it doesn't have to be all your plans, just the lowest cost plan, does not exceed more than 9.5% of household income. Now, 9.5% is the percent that's in the actual act, but that percentage is indexed every year, which means it's a little bit higher. This is tricky because, of course, employers don't know what household income is. You obviously know how much your employees make, but you don't know how much other members of your employee families brings in. So the tri-agencies or departments, or the 3 U.S. departments, understood this, and so they created in the regulations 3 affordability safe harbors. The options are, of these 3, the federal poverty level safe harbor, the rate of pay safe harbor, and the W-2 method safe harbor. If what you charge per month falls within one of these 3 safe harbors, then you will be considered to have met affordability. So we always recommend that you use one of the safe harbors. Now, the other key thing here is to remember that it's very important to select an affordability safe harbor every single year, just before the beginning of your next plan year. This helps you not only make sure that you are offering an affordable plan and helps you avoid employer mandate penalties, but it also is an important thing to understand and select, so that you know how to properly code on your 1095 reporting forms. So there's a couple of really good reasons it's important to select an affordability safe harbor each year, and remember, just prior to the beginning of your plan year, so that you don't have to make changes mid-year because you realize you're not meeting affordability. Now, affordability can be tricky, but we've made it simple for you. GBS has a toolkit for you that includes a calculator with all these safe harbors. So if you use we actually have 4 steps to compliance with the employer mandate, but step 3 is about the affordability and minimum value, and it helps you confirm that in an easy, quick way. So remember to use our step 3 of the GBS 4 steps to compliance every year, just prior to the beginning of your plan year, when you're trying to make decisions about how much you're going to charge for single coverage on your next group health plan. So you may be thinking to yourself, if this is all new to you, how do you actually calculate the penalty. So I've got a chart here for you just in case you're curious about this, and I've got it divided into the A penalty and the B penalty. So let's talk about let's use line 2019. The IRS is typical. This is how they work a couple of years behind the current calendar year. So the penalty letters we're seeing now are 2019. So if you were to get a penalty now, it would probably a penalty letter now, you would probably be based on 2019. And if you were to be assessed an A penalty, it would be calculated by taking based on 2019 by taking $2,500 multiplied by all your full-time employees minus 30. For example, if you have 100 employees, and that would be 2,500 multiplied by 70 full-time employees. Now, if you were to be assessed with a B penalty, that's cheaper. Let's go across on line 2019. If you that is calculated by taking 3,750 multiplied by all your full-time employees who went to the marketplace exchange and obtained a subsidy for that month. So say, for example, if you had 3 full-time employees who, let's say for the year, if you had 3 employees, full-time employees, who got a subsidy for all 12 months of the year, it would be 3,750 multiplied by 3. Now, the penalty breakdown on the prior slide was based on the assumption that an employer had an employee get a subsidy for all 12 months of the year. Those numbers were based on all 12 months. So here is a penalty breakdown on a monthly basis, because in reality the IRS assesses the penalty per month based on whether an full-time employee received a subsidy in that month. So for 2022, a monthly penalty multiplier for the A penalty would be $2,029.17 multiplied by all the full-time employees. Even if they were offered coverage, it's all full-time employees minus 30. And then a B penalty for 2022 per month instead of annually would be $343.33 multiplied by all full-time employees who went to the marketplace exchange in that month and obtained a subsidy. Now, you may be thinking, well, how does the IRS even discover whether I, as a large employer, offered affordable minimum value coverage to my full-time employees? And the answer to that is that the IRS discovers it through the 1094, 1095 forms and other information that is kind of mashed up together electronically. So let's back up on that. The ACA requires the IRS to regulate along with the HHS and DOL, but they are required to regulate the employer mandate, individual mandate, and the exchange, and the combined information provided by the A forms, the B forms, and the C forms, the 1094, 1095 A, B, and C forms provide the IRS with the necessary data to discover who's not compliant with the employer mandate. So unless you've worked with the 1094, 1095 forms, you might have been confused when I said the 1094, 1095 forms and the A forms, the B forms, and the C forms. So here's a slide just with the main overview of what these forms are and who has to report. The exchange marketplace actually has to prepare 1095A forms. They're the ones who get the A forms, and those forms are created for all individuals who purchased coverage in the exchange and received a subsidy. And those forms go to the individual who received the subsidy and to the IRS. The next category are the B forms, and those forms are created by providers, meaning carriers and insurers, but they also are created by small employers who sponsor self or level funded plans. And the information that they're providing in that, or the people that they are giving these B forms to, are those who were enrolled in their plan. So those forms go to the particular individual who is enrolled in their plan, and to those and to the Treasury, the IRS. And the last category are the C forms. And those forms are created by large employers. Whether they're sponsoring a plan that's insured or self or level funded, all large employers under the rules need to prepare the 1094-C form and all the 1095-C forms. And who do those go to? Those are given to all full-time employees. In other words, who was offered coverage, and was it minimum essential coverage, minimum value, and affordable? So all full-time employees, whether they were offered coverage or not, need to be given a 1095-C form. And the cover sheet, the 1094-C form, is filed with the IRS, and the 1095-C form goes to all employees. We are going to continue talking about the 1094, 1095 forms just briefly for a couple of slides. And the point I want to make on this slide is that it's important to remember that there are separate penalties under employer mandate and for reporting. In other words, we've talked about the penalties for employer mandate, the A penalty and the B penalty. But it's also important to remember that information reporting using the 1094, 1095 forms also carry penalties. And an employer could be imposed, the IRS could impose penalties on an employer that fails to file or furnish the 1094, 1095 forms, or that files incorrect or incomplete forms, or files or furnishes the forms late. So again, we've seen different IRS penalty letters. Some of the penalty letters deal with the employer mandate, and some of the penalty letters deal with problems with the actual 1094, 1095 forms. Here is a chart that indicates some of the penalties that could be imposed by the IRS on an employer. And I know this is a lot of information here, but I want to focus on two of the lines. The first line, failure to file or furnish, whether it's the B form or the C form, would be $280 per form for 2022. So that could really add up if you are a large employer for failing to do that. But the thing I want to point out here is that is, if that's mistaken, meaning you didn't understand you were supposed to do that. If you look at the bottom line, penalty for filing in case of intentional disregard, that penalty doubles. So if you understand that you're supposed to be filing the 1094, 1095 forms, and you just specifically decide or intentionally decide not to, then per form, at least for 2022, it would be $570. One last slide before we move on to another topic. And I've added this slide because I get asked this question often: which employers must report? The general rule is that all applicable large employers report. Applicable large employers, ALEs, all the same thing, must report using the C forms. Some, but not all, small employers report. Again, some, but not all, small employers must report. If you're a small employer who sponsors an insured plan, you don't need to report. But if you're a small employer that sponsors a self or level funded plan, then you must report. But remember that you only need to complete the B forms. The B forms are not nearly as complex. If you are an employer that think you are small, it is important to confirm your size each year. We've had groups who thought that they were small and actually were large and had no idea they were exposed to large employer penalties under the employer mandate. So we recommend that you use our GBS 4 Steps to Compliance Toolkit. I referenced this toolkit a couple of slides back. It has 4 steps, obviously, We talked about step 3, which was the affordability and minimum value confirmation, but the step 1 actually helps you calculate your size, and we have a calculator which makes the process a whole lot easier. So again, if you're a small employer and you haven't ever confirmed your size, there are specific rules about individuals that you must include and you don't need to include. You want to make sure you understand and follow those specific calculation rules. Now, there's also a special rule for reporting if you do actually have to report because you're small. Starting with the 2019 reporting year, small employers who sponsor a self or level funded plan can forego populating the B forms as long as they follow certain other kind of alternative rules. In my opinion, it might just be easier to cover your bases and just do the B forms because they're easier. But we explain all the 1094, 1095 reporting rules in a separate webinar that is all about reporting. And so if you have any questions about that, make sure that you participate in that. We usually provide an updated reporting seminar in December of every year. So what we've talked about so far in our presentation is an overview or some basic background information about the ACA. Then we are going to talk about each of the 4 parts of the ACA, and we've talked already about the exchange, and we've talked about the employer mandate, and now we're going to talk about the individual mandate. The general rule under the individual mandate is that all individuals must obtain minimum essential coverage or MEC for themselves and their dependents or pay a possible penalty or what in essence is a tax. That tax is calculated on a monthly basis but is paid annually basically on your tax forms. Now there were exceptions to this tax that I've got listed here, but probably the most applicable one here is that there can be a 3-month or less gap in coverage, but other than that, all individuals must obtain that minimum essential coverage. And again, minimum essential coverage is just basic health coverage. It's not minimum value, it's not affordability thresholds, it's just basic coverage. Now that was the general rule, but there have been changes to the individual mandate. The individual mandate was gutted basically in the Tax Cuts and Jobs Act back in 2017. And what that did in essence was change the tax amount from the thresholds that were included in the rule to 0. So in essence, the mandate still technically exists, the individual mandate, but it was not repealed. In other words, it was not repealed, but it does not have any teeth because the tax is 0. These changes were effective starting January of 2019, but no other ACA provisions were changed. So what is the effect of this change? Well, individuals no longer have to pay a penalty or extra tax if they don't enroll themselves and their dependents in group or individual health coverage. It was hard to predict what some of the effects of this would be. Would it hurt the ACA as a whole? Would it not? So far, and what it looks like the effect is that it really hasn't changed much, other than, and it hasn't changed much because many people still want health coverage even without the rules. So people opt into coverage because there's a lot of good reasons to have it. Large employers still need to offer coverage under the employer mandate. Nothing has changed under those rules. But you may have seen in some certain industries participation in your group health plan go down a little bit, but anecdotally I have not heard any of that being actually true. Back when we were discussing the overview of the ACA at the beginning of this presentation, I mentioned that the U.S. Supreme Court has addressed the ACA 3 times. So here are the 3 times. They all had to do with the individual mandate. One time in 2012, another time in 2015, and another time in 2021. We won't get into the details of this, just to say that you may have heard of certain cases and be confused about what that meant, but the court in each of those cases didn't make any changes to the rules. It's important to talk about the individual mandate, even though currently the penalty is 0, because the individual mandate could affect you in a different way. This is because in certain states, there are individual mandate type state laws that are very similar to the ACA federal individual mandate rule, and those rules actually have some teeth because they have some penalties. So these state laws require, generally, these state laws require individuals and families to purchase medical health coverage or insurance, just like the ACA individual mandate. Some of these state laws were created before the federal ACA, and some were created before the change in 2017 that were effective in 2019. But most of these state laws were created in response to the penalty change to 0. And these states are California, Massachusetts, New Jersey, Vermont, Rhode Island, and District of Columbia. So if you have any employees in any of these states, it's important for you to understand that there are some reporting requirements that are state rules that employer needs to follow. Now, this reporting is similar with a few exceptions to the ACA 1094-1095 reporting. We won't cover that in detail today because this is not about reporting mostly. This presentation is about an overview 101. And so if you want a little bit more detail on that, ask for our GBS summary that's entitled State-Specific Individual Mandate Rules and Annual Information Reporting Requirements. So we have discussed so far in our presentation the overview, the exchange, the employer mandate, and the individual mandate. Before we move on to market reforms, we're going to take a quick side topic and talk about the GBS tools that have been created to help assist you with compliance. The GBS tools were created to help you comply with the employer mandate, and we've talked about this already. I've mentioned it, step 1 and step 3 already. The GBS 4 steps to compliance toolkits. We have a toolkit for step 1, toolkit for step 2, and 3 and 4. We also have some resources to help you understand and comply with the 1094-1095 reporting. So we're going to just take one slide to give you an overview of the 4-step toolkit. Again, this is a toolkit to help you get in compliance with employer mandate. As you were listening during that portion of the presentation, you might have felt a little overwhelmed. That is pretty common. So we've created these steps to help make it a little bit easier to navigate. Step 1 is determine your employer size, whether you're large or small. If you're large, you need to comply. If you're small, you do not. Step 2 is determine your initial compliance date when you're first exposed to penalties. Step 3 is determine what will be offered. That was the step we talked about when we were talking about affordability and minimum value. It's important to make sure you are using this step every single year just prior to the beginning of your plan year. These other steps you only need to do once typically, unless you're a small employer and you'll want to repeat step 1 every year. But if you're large, you'll do all these steps once and then repeat step 3 every year. Step 4 is determine which employees will be offered coverage and when, and basically that step involves being educated in the measurement methods and learning about and creating your written measurement method policy. Another important tool that we hope that you take advantage of is our reporting seminar. 1094-1095 reporting is pretty simple if you do the B forms, but if you are a large employer and you need to populate the C forms, there's a lot of information for you to understand. Now, you may have vendors that help you populate these forms, but you're ultimately responsible for making sure those forms are filed and they're accurate and they're on time. So in order to do that, you need to understand the rules and what to look for when you're checking those forms that were populated by your vendor. This webinar / seminar, depending on the form you attend, goes line by line. after an overview for each of the forms. The B forms, which is a lot quicker, and then we go into some detail with the C form, again line by line so you know what you're looking for, and we also answer a lot of frequently asked questions. Let's move on to market reforms. So far, we have talked about the exchange marketplace and the subsidies that some individuals may qualify for. We've also talked about how that interacts with the employer mandate and the individual mandate. Hopefully you can see now how these three provisions create the heart of the Affordable Care Act. We're now going to move on to market reforms. Market reforms is kind of a catch-all phrase because there are several additional provisions that were included in the Affordable Care Act that were intended to create some improvements as well. Here is a list of the provisions that affect employers. Now, I don't want you to get overwhelmed by this list. There are a lot of things here. You'll notice that on the left-hand side we have items that are in bold, and those on the right are lighter. The reason for this is to let you know that those on the right that are lighter are provisions that you need to be aware of, but are most likely going to be taken care of for you. They're sort of built in now to Affordable Care Act, and it's not news, and it should be already just part of your process. However, on the left-hand side, these are items that you need to specifically be aware of because you may need to take specific steps in order to comply. ACA notices. There are two here. One for sure applies to all of you. The other one may or may not apply. Likely not. The exchange notice applies to everyone. It actually applies to employers even if they don't offer a group health plan. The exchange notice is a notice that explains the state exchange marketplace health insurance options. All employers, like I said, no matter what size, no matter what kind of funding, and even if they don't provide a group health plan, like I said, need to provide this notice to all newly hired employees within 14 days of hire. There are model notices that are on the DOL website, but we also have these notices in our notices packet. You don't actually have to use the model notice, you just need to make sure you get that information out. And there's also some interaction with COBRA. The COBRA notice was also updated to include information about the exchange and the marketplace. Then we also have a grandfathered plan notice. A grandfathered plan is a plan that has kept certain provisions and not made certain changes since the beginning of the Affordable Care Act in 2010. Most plans today are not grandfathered. However, if you happen to have a grandfathered plan, you want to make sure that you are aware of and providing this grandfathered plan notice. ACA fees. There are actually several ACA fees, some of which, a lot of which are either repealed or have expired already. But we're going to talk here on this slide about the PCORI fee, because this one was supposed to expire by now, but it was actually extended and is currently a requirement. So the PCORI fee is a fee that helps fund the Patient-Centered Outcomes Research Institute, which is an institute that was created by the ACA. This institute is intended to research and provide information for the public about healthcare outcomes in an objective way. The fee was initially supposed to be effective from 2012 to 2019, but it was extended an additional 10 years. So it's still effective at least through 2029. And this is, again, one of those provisions that is not a polarizing issue. I think at the level of Congress in DC, everybody's agreeing with this one. The fee amount started at $1 per covered life, but it is indexed each year based on medical inflation. So every year that amount will increase a little bit. Only employers with self or level funded group health plan, regardless of your size, need to submit the fee. If you are sponsoring a insured plan, your carrier will take care of that fee for you. Now, the important thing to remember here, because we're not going to dive into the weeds on this one, is that If you do sponsor a self or level funded plan, you need to make sure that you're counting the number of covered lives correctly, and you have 3 specific methods that you can use to make that calculation, and we've got a summary for you in order to help you understand how to do that. Here is a list of the ACA fees that have either expired or been repealed. This is just for your reading enjoyment. I won't go into any details, but if you happen to have a question about it and something pops up, you know that the transitional reinsurance fee, the Cadillac tax, and the HIT tax have either expired or been repealed. The ACA 90-day waiting period sometimes gets confused with the employer mandate, but this particular provision applies to all group health plans of all sizes, no matter the funding. So that includes small employers as well. The rule here is that once an individual is eligible for health benefits, an employer cannot make an employee wait beyond 90 days. So practically speaking, this means that a waiting period, because carriers like things to onboard individuals on the first of the month in most cases, this practically speaking means that a waiting period should be no later than the first of the month following 2 months. Now, we also have a really common question that comes up related to this topic. And the question is, can we have different waiting periods for different categories of employees? The answer is it depends. Isn't that fun? But generally we would say, no, do not do that. It's allowed, the reason why is because it's allowed under certain federal health benefits rules and not allowed under other federal health benefits rules. Because we're talking about the ACA, and if that question were asked, can we do this under the ACA? The question would be yes, you can do that under the ACA. You could also do it under the HIPAA rules as long as you're using a reasonable business classification for those categories that is not related to a health factor. The problem is that under yet another set of federal rules that are found in the Internal Revenue Code, including Section 125, which are the rules that have to do with cafeteria plans, and Section 105H, which are the rules that have to do with self-funded plans, it is not a good idea. That is because there are certain non-discrimination rules there that we know if you have a different waiting period for different categories, you're going to run into some problems. So again, generally we would say you can treat some individuals differently when it comes to health benefits, but not when it comes to waiting periods after an individual is eligible. The SBC, or the ACA Summary of Benefits and Coverage, sometimes gets confused with other ERISA documents like Summary Plan Description or Summary of Material Change or Modification. But this is a separate ACA document that is a simplified explanation of benefit that summarizes the health plan and defines certain basic terminology. And the point of this is so that your employees, and other consumers can easily compare plans side by side. If you're offering more than one, they could literally lay these SBCs side by side. If you're offering only one plan, they could compare that to other options they may have through a spouse or through the exchange and so on. The thing that's important to remember here is that this is required for all employers of all sizes, and it must be provided in a 4-page standardized form, again for all plans. I like to compare this standardized form to the nutrition facts on items of food that we can purchase. You know, you can compare those items and you can easily compare when you're shopping for food what are the ingredients and certain key information, and that's what's kind of the idea here with the SBC. The SBC must be distributed at specific key times at open enrollment. If you don't have open enrollment, no later than 30 days prior to the first day of the new plan year, and then of course no later than 7 days following a request from an employee or a participant. There benefits that do not need to have an SBC. For example, certain accepted benefits like limited scope dental and vision benefits, HSAs, and health FSAs. ACA Form W-2 reporting sometimes gets missed or overlooked because it gets confused with the other ACA reporting. I think a lot of times when we hear reporting, we jump to or assume we're talking about 1094, 1095 forms, but this is a different requirement. This is a requirement that an employer who is large, and we'll talk about what that means in a minute, must put in box 12 using code DD on the W-2 form for each individual the total value of the coverage that was offered to that individual. The value of that coverage includes both the employee cost and the employer cost. Now let's talk about what that means for large employers and how that's defined. Again, only large employers must comply with this rule, but large employers are defined differently in this provision than they are under employer mandate. Under employer mandate, if you recall, a large employer, or ALE, is one that has an average of at least 50 full-time employees plus full-time equivalents over the prior calendar year. In this case, a large employer is defined as one who filed in the prior calendar year 250 or more W-2 forms. If you are an employer who did that, then the following year you need to make sure that you're reporting the box 12 information on your W-2 forms. The ACA medical loss ratio rebates. The rebate itself, the MLR rebate as it's sometimes referred to, is a portion of premium payments that are refunded by the carrier back to the insured group that sponsored an insured group health plan. Now, the medical loss ratio, let's talk about that for a minute. A carrier must spend, on an insured plan, must spend a minimum % of monthly premiums it received from an insured group health plan on the plans themselves versus administrative costs or bonuses or so on. So if you are in a small group, if you're quoting in a small group, the carrier must spend at least 80% of premium revenues back on the plan. And if you're in a large group, the carrier must spend at least 85% back on the plan itself. Now, if this ratio is not met, carriers again must refund a portion of that. Now, it's important to understand that the rebate is based on average MLR or medical loss ratio within a risk pool and not on individual group policies. So for example, if a carrier does not meet the specific 80% for all of its small groups in a particular area, it must provide a rebate to all plan sponsors in that small group pool. To avoid complicated, here's the key thing, to avoid complicated trust rules and processes, as well as possible penalties, the employer should redistribute that money, that refund that you get, and you'll get that in the fall, using proper distribution rules within 3 months after you receive that. If you go beyond the 3 months and have not yet distributed, you're going to have to deal with a whole host of trust rules and processes. So again, the takeaway from this is if you get the refund, make sure you get up to speed on how you distribute properly and actually do the distribution within 3 months. Now we have a GBS summary on the topic. Like all of these topics, we have a summary on that, so let us know if you'd like that information so you can dig in a little bit more. The ACA also addressed wellness incentives. So for certain results-based wellness program standards, employers can offer either financial incentives or sometimes penalties, depends on how you want to approach it, of up to 30% of the total premium cost or cost of coverage in the group health plan. Now, an additional 20% incentive is allowed for wellness programs to reduce or stop tobacco use. So the total incentive maximum is 50% of the total premium cost. Now, of course, there are other rules that come into play here when you have a wellness program, including a wellness program with incentives that fall under HIPAA, ADA, and GINA. So the takeaway on this slide is if you have a wellness program, or if you would like to explore the idea of having a wellness program, we have a fabulous GBS wellness team who is very well versed in these rules and ideas and options, and will help you navigate appropriately and in a compliant way any sort of wellness program. The ACA added a rule that requires all health plans, including group health plans offered by employers, to continue coverage for dependents up until those dependent children reach age 26. And that includes dependents who have other group coverage available. So, and it also includes dependents up to age 26 even if they're married. So a dependent child is defined as a daughter, stepchild, adopted child, foster child. The ACA also added a rule prohibiting pre-existing condition exclusions. Now, a pre-existing condition exclusion is any limitation, exclusion, or denial of benefits based on a condition present before the effective date of coverage. It doesn't matter whether the condition was known, unknown, treated, or untreated at any time before the effective coverage date. So now group health plans are prohibited from imposing these kinds of conditions on any employee or on any of their dependents of any age. The ACA implemented certain external review procedures as well as internal claims and appeals processes. For the external review, the general idea here is that group health plans must comply with the consumer protections in the NAIC Model Act, depending on whether the plan is insured or self-funded. In addition, group health plans must implement internal claims and appeals processes that comply with Section 503 of ERISA. And within that, there are additional 6 ACA requirements. As an additional note to these review processes, whether it's external or internal, there are new transparency rules that implement some processes as well. If you have any questions about this, you will get a lot of information from your carrier or your third-party administrator. Under the ACA, new rating rules were implemented. Specifically for individual and small group policies, carriers can now only set rates based or consider or look at 4 factors when they are providing rates, and those are age, and those are only allowed at a 3-to-1 ratio, geographic area, tier, meaning single, family, etc., and tobacco use. Now, there are some exceptions to the modified community rating rules, and that includes self or level funded plans, grandfather plans, and certain grandmothered plans. Now, we have a couple of additional slides with information that kind of interact or dovetail with this particular slide. You may have heard reference to the essential health benefits. This is an ACA term, and what it means is that individuals and small group health plans must include in their plan 10 quote-unquote essential benefits that meet certain values. Now we'll talk about what those 10 basic essential health benefits are on the next slide, but I first want to talk about the exceptions to these rules. Because this rule applies to individual and small group health plans, it does not apply to large group health plans or small group health plans that are self or level funded. It doesn't apply to grandfather plans and grandmother plans. Here is a list of the essential health benefits that must be included in individual and small group plans. The reason I think behind not requiring large groups to provide these, as most large group plans already do. So the items are ambulatory patient services, hospitalization, mental health, emergency service, maternity and newborn care, prescription drugs, rehabilitation and habilitative services and devices, lab services, pediatric services, including oral and vision care, and preventive and wellness service and chronic disease management. Now, the parameters for what the details within these 10 categories are answered at the state level. The state is supposed to set the parameters. For example, specifically which prescription drugs, which lab services, and so on. The ACA prohibits annual and lifetime limits on any of the 10 essential health benefits. Now, this means all plans. So for example, even though large plans are not required to provide the 10 essential health benefits in their group health plan, they may not limit any of the 10 essential health benefits that they do include in the plan. So again, any plan of any size that offers any of the 10 essential health benefits may not apply to those essential health benefits any annual or lifetime limits. The ACA prohibits excessive cost sharing. And remember, cost sharing are out-of-pocket costs. Sometimes they're referred to as OOPs, and these limits are sometimes referred to as MOPs, or maximum out-of-pockets. Now, these rules apply to all size plans, whether small or large, and all types of funding, whether self or level funded or insured, but they do not apply to grandfathered plans. Now, we don't have very many, as we discussed before, plans anymore that are grandfathered, but if you happen to have a plan that's grandfathered, these particular limits do not apply to you. In addition, we do have deductibles that cannot exceed specific amounts each year, and those amounts are adjusted as well. The ACA also has specific rules about preventive services and the cost of preventive services. Specifically, group health plans must pay for a certain specified list of preventive services even before the participant has met his or her deductible, and the participant cannot be required to pay any co-payment, co-insurance, or other sort of cost sharing. Examples of some of these preventive services include counseling from your healthcare provider on topics like smoking, losing weight, eating better, treating depression, and so on. Vaccinations, services that help create healthy pregnancies, services that prevent heart disease and obesity, and cancer prevention services as well. Along with the preventive services, there are specific preventive services for women that were added by the ACA. Specifically, and for example, group health plans must provide coverage for well women visits, breastfeeding support, domestic violence screening, and contraceptives. Now, contraceptives have been a little bit on the radar given the Dobbs case that was recently issued by the U.S. Supreme Court on abortion. But it's important to note here that nothing changed in terms of on the issue of contraceptives, and plans must, unless they fall within a limited exception, must provide contraceptives without cost sharing. A lot of the ACA provisions here that we're talking about within the market reforms are aimed at adding and strengthening patient protections, but there's also an additional catch-all area under the ACA that addresses patient protections, and some of these are that a group health plan must allow participants to select their own pediatrician. They cannot require a referral or pre-authorization for an OBGYN or for emergency care, and they cannot impose additional costs or limits on out-of-network emergency care. Now, the recent transparency rules that were passed, that it's a separate topic that we're not really addressing in this ACA presentation, also addresses some of these costs. So it helps strengthen some of these rules. The ACA also added rules about clinical trials. Specifically, group health plans may not deny coverage for a participant participating in approved clinical trials for treatment of cancer or other life-threatening disease. Group health plans may not deny, limit, or impose additional conditions for coverage of routine-related patient costs when it comes to clinical trials. And group health plans may not discriminate against individuals for participating in approved clinical trials. The ACA also addressed over-the-counter drugs. Under the ACA, non-prescription drugs are not reimbursable through health FSA, HSAs, MSAs, or HRAs unless they are turned into a prescription by a doctor. Now, there are exceptions to this rule. For example, insulin, even if purchased without a prescription, is still considered a qualifying medical expense and is reimbursable through these tax advantage arrangements like the health FSA and HSAs and so on. But then there was a change to this rule due to COVID through the CARES Act. The CARES Act was passed in March of 2020 and effective retroactively starting January 1, 2020. Over-the-counter drugs, along with menstrual care products, are qualified medical expenses that actually may be reimbursed through your HSAs and HRAs and so on. So that's a lot of market reform provisions to go over, but we've just completed our list and just want to add a slide on penalties because I'm asked this question rather frequently. What happens if we don't comply with some of these rules? Well, we have specific penalties on some of these market reforms, and for others there is a catch-all penalty. For the SBC, remember the summary of benefits and coverage, an employer group health plan could be imposed a $1,000 penalty for willful failure to comply. And for most other market reform provisions, the general catch-all penalty amounts apply. And that amount is $100 per day per affected participant per provision that is violated. Now that $100, like a lot of these other amounts that we've listed, are indexed each year based on medical inflation. And there are exceptions under this kind of catch-all penalty amount. If an employer can demonstrate it did not know that there was a compliance failure and that failure was due to reasonable cause rather than willful or intentional neglect, and was corrected within 30 days of discovery. That completes our presentation on Affordable Care Act 101, what employers need to know. Hopefully you've gotten some information that helps you have a general understanding of the overall ACA and a little bit of specific understanding on each provision. Remember that we have all kinds of resources here at GBS that will help you understand each of these things that we've discussed in more detail, some of which also have some great tools that will help simplify this process for you. Don't hesitate to reach out to your team for additional help.